Okay, hello, good morning everyone, and thank you for coming for today's session. Just to introduce myself, my name is David. I'm a consultant radiation oncologist. I practice at Concord International Hospital, which is along Adam Road, and I'm also part of Asian American Radiation and Oncology in Gleneagles Hospital. Introduction about myself, a bit more in terms of my training. I am a clinical oncologist by training. This means that we are trained in delivering both radiotherapy and chemotherapy treatments. In Singapore, we focus on delivering radiotherapy treatments in bringing cutting-edge technology in order to target cancer precisely. The topic for today that I'm going to give is about recognizing and treating lung cancer in the 21st century with the tagline precise, personalized, and promising. It is a lot of information. The US guidelines on how to treat cancer spans about 220 pages, and we are trying to compress that into 20 minutes. So sit tight as I try to give you as concise and as precise a summary as we can in this talk. Let's start off by defining what is an oncologist. I think this is often something that we question, right? What is an oncologist? Is he a surgeon? Is he a GP? Is he something else? Well, an oncologist are actually specialist doctors who focus on the non-surgical management of cancer. Oncologists in general are either trained in chemotherapy alone, radiation therapy alone, or are dual trained, like in clinical oncology. So, and in general, when a patient gets cancer, the oncologist is responsible for coordinating their entire cancer care and their journey, which often involves multiple care providers, including surgeons, physicians, radiologists, and so forth. So with that, let's look at the goals of today's talk. I think first of all, we want to provide an overview of lung cancer incidence and mortality rates in Singapore. I want to highlight the advances in the diagnosis and treatment of lung cancer in the 21st century. And hopefully by the end of the talk, I want us to appreciate that in the era of modern cancer treatments and advances, that lung cancer is no longer a death sentence. So let's start off. This is actually published very prominently outside. It tells us what is lung cancer. I think what we can say as we look at this in first glance is that cancer is deadly. Lung cancer is deadly. It is the number one cause of cancer death in males, number two cause of cancer death in females. As Professor Eng has brought as well, it is one of the commonest cancer, the most common cancer in males and the second most common in females. Many patients with lung cancer are diagnosed at an elderly age, above 50 or 60 years of age, and majority of lung cancers are diagnosed at a late stage. Again, looking at the top 10 cancers diagnosed, lung cancer is the second most common in males and the third most common in females. And in terms of death, not to belabor the point again, it is the top cause of cancer death in males and the second cause in females. So we are dealing with a cancer that is deadly, a cancer that is common, a big problem for many of us oncologists. So what have we to offer in this age? I'm going to start with this comic strip that kind of sums up. It meant a lot to me when I actually went searching for comic strips, because I say this is a public talk, it's a morning talk, people will be sleepy. So hopefully it's something that you appreciate. This is an encounter of a cancer patient with an oncologist. And obviously, nobody's going to be happy seeing us. Our job is a little bit depressing at times. People are not happy to see us. But I think at the same time, as oncologists, being given this responsibility to treat such a deadly cancer, we have to take this on and we have to face this positively. And therefore, I think from our perspective, we look at it differently. You are here to see me. You may not be happy, but likewise, the cancer cells are not happy as well. And let's focus and work together to make cancer's worst nightmare come true. I want to liken this battle to lung cancer as a form of warfare, a form of battle. And so we are looking now, we're going into 21st century warfare against lung cancer. As the title implies, there are two main elements in this battle against lung cancer. Very similar to military operations. The first very important phase in targeting and fighting lung cancer is in recognizing it well. Very similar to the way reconnaissance is performed in the military. You spend months and even years preparing for war. And part of the preparations is collecting intelligence about the enemy, knowing them well in order to finally treat and target our enemy. So recognizing the cancer comprises of advanced imaging, targeted biopsies of the tumor, and precise histological, and in the 21st century, molecular analysis. We then move on to treating the cancer. That is the second and equally important aspect of 21st century cancer warfare. And in this era, we have options available to us. We have surgery, radiotherapy, chemotherapy, targeted therapy, and immunotherapy. Very similar to the land, air, and sea wars that we have in warfare. So let's talk about recognizing lung cancer in the past. These modalities of diagnosis was actually used probably about 20 years ago, 15 to 20 years ago. And we were looking at that era in using chest x-rays to diagnose cancer, sputum cytology, CT chest and abdomen, a bone scan to ensure that there's no bony spread, as well as immunohistochemistry staining. This is where you obtain a biopsy of the tumor, you look at the tumor closely under the microscope, and you recognize patterns that tell us that this is a specific cancer type. In the 21st century, recognition of it has become more precise and personalized. And we are now no longer dealing with gray, black, gray, and white, as in the previous era, but more in terms of dynamic scans. We are now have PET scans available to us, which is the injection of specialized dyes that will go to cancer cells that are growing fast. We also have techniques, more increasingly advanced techniques to perform biopsies. We are able to get to the cancer cells more accurately. We can insert a tube through the nose, through the airway, into even the tiniest airways in the lungs in order to visualize the tumor. And we have molecular testing. And this is really one of the most revolutionary findings and advances in the 21st century. In the past, and you will recognize this, recognition of cancer cells would be through the microscope, recognizing of patterns and diagnosing that this is a non-squamous histology or a squamous histology. And diagnosis would stop here. Treatment would then be prescribed based on what we find on the patterns on the cells. However, where we have moved to in this era is in going even deeper to the level of the gene, to the level of the molecules within the cell, and we can now detect the signature of various markers within cancer cells that differs from individual to individual. And what more, once we identify these targets with these methods, we can then prescribe and tailor the right treatment to specifically treat those weak spots in the cancer cells. So this is where we are. We're going to go a bit deeper into this later on, but just for you to appreciate that diagnosing, recognizing cancer in the 21st century has changed, and we now have available to us advanced imaging and advanced options to profile the tumor and to target them more accurately. So how about treating cancer in the 21st century? How far have we gone? This is the Cancer Moonshot program that was initiated by the US to try to further advances in cancer research and to compress 10 years worth of research into 5 years, try to accomplish what we would usually do in 10 years in 5 years. And I think we've managed to do that in the last 20 years, 18 years of the 21st century. This is what it would be like to treat cancer in the past. There were 3 main modalities: surgery, radiotherapy, and chemotherapy. And if you delve deep into the details of these treatment modalities, you would see that these methods in the past were very crude. Surgery for lung cancer would involve a huge incision over the left or right side of the chest, pulling open the skin, assessing the lung cavity, and removing the tumor from there. Radiotherapy, on the other hand, would be planned using simple x-rays, treating a large area of the lung, and even in the so-called slightly more advanced ways of planning, you see large swaths of lung being involved in the radiotherapy beam. Chemotherapy, on the other hand, something that many people was fearful at the past. The chemotherapy at that time and in the past dealt and focused on the genetic makeup of fast-growing cells. So it would target cells that were dividing very quickly. And we all know that we have fast-dividing cells, normal cells in our body. These include the hair, the skin, the liver, and so forth. And so this chemotherapy, while they would be able to kill fast-growing cancer cells, would also kill many of the normal cells in our body, resulting in things like hair loss and severe symptoms in the liver or even the kidneys. So this was how we would treat lung cancer in the past. And how have we changed now? I think what we see is that, first of all, we have more treatment modalities added on. What used to be surgery, radiotherapy, and chemotherapy have now been augmented by the introduction of targeted therapy and immunotherapy treatments. If we look deeper into the details, we see that the surgery has changed as well. We are no longer looking at large incisions. There are minimally invasive techniques to reduce complications from surgery and to improve and to shorten hospital stay. Radiotherapy has now become more and more advanced and more intricate. We now use CT scans for planning. We have special techniques to limit the dose to just the area that we want to treat. And of course, we have targeted treatments and immunotherapies that have come into the mix. It's a lot to stomach. As I said, it's 220 pages of guidelines. I think the best way for us to approach this would be to now switch modes, to go a bit deeper, and to look at how we would manage lung cancers stage by stage. And as we deal into the options that we have for every stage, I will just focus on some of the latest advances that we have, some of the most important and critical changes that we have made to our treatment algorithms. So let's start with the treatment of early stage lung cancer. This is defined, in this case, as stage 1 and 2 non-small cell lung cancer. In general, these are cancers that are relatively small. They are cancers who have not invaded into the critical central structures, such as the esophagus, the trachea, and the heart, and thus rendering these patients operable and potentially curable. So for every stage of cancer, I'm going to give you a few underlined statements, key statements, to tell us what are the main modalities of treatment, and then we'll go into some of the more precise details. In stage 1 and 2 lung cancers, the mainstay of treatment would be surgery or radiotherapy. Okay, breaking it down, there are options within each of these modalities, such as stereotactic radiotherapy, which is a very advanced form of radiotherapy, conventional radiotherapy alone, and occasionally the addition of chemotherapy to our radiation treatment. Let's look at surgery for non-small cell lung cancer. Early lung cancer, this is considered gold standard of treatment where possible. So if you're well, you're fit, you have an early lung cancer, the first choice of treatment for you would be surgery to remove the tumor and to potentially cure this condition. The advantages of surgery are that the tumor can be removed and it can then be examined under the microscope. It is also a one-off procedure, so unlike chemotherapy or radiotherapy where you have to come back for recurring visits, surgery cures the cancer in a one-off setting. The type of surgery obviously will depend on the location and the extent of tumor. If the mass is in a good location, we can get away with just removing a little bit of lung. If it is in a more central location, we have to remove a lobe of the lung or segment, a larger part of the lobe, and in some cases we have to potentially even remove the lobe, half of the lung, or even the entire lung. However, in the 21st century, we have now learned and gotten used to minimally invasive surgical techniques, which have resulted, as I mentioned before, in fewer complications and shorter lengths of stay. Just to demonstrate how lung surgery has evolved, this was lung surgery in the past, a huge incision. This is lung surgery at present, what we call VATS, or video-assisted thoracoscopic surgery. Usually there will be two surgeons holding various ports that will enter into the patient's body with cameras attached. Whatever you see in the ports would be reflected on the screen. And it's almost like a video game, right? You hold a controller, you move it, and then you see the port moving. A lot of surgeons, I know, they actually practice on Xbox or PlayStation. I think you can ask some of the urologists later. But this is really what they do. It's very fun, right, their job. So the other type of surgery is robot-assisted surgery. It is the same concept. You have various ports of entry over here. And the surgeons are actually not over the patient. They're actually looking into this robotic system that are connected to all these arms over here. So they're actually looking into a screen at a distance from the patient, and they're controlling the robotic arms. And the advantage of this is that the robotic arms do not shake, and they are not subject to erratic movements of our hands at times. So they are very stable, and sometimes they provide a level of precision that is unheard of with manual surgery. And we see the difference here on the patient. This would be a traditional scar that would be about 24 centimeters, and with new techniques now we have tiny scars that are formed around the patient. There is one problem, however, and that is that in surgery for lung, if you look at the demographics of patients who have lung cancer, the patients who are getting it are in the range of 60, 70, and 80 years old. This is an elderly population, pre-existing illnesses, most likely with a long smoking history and with a high risk of surgery. And that renders them what we would call medically inoperable. So we will have a bunch of patients with early stage lung cancer, and for which we know that the gold standard is surgery, but who cannot undergo this form of treatment. What do we have for them? Radiotherapy would then be the next option. In the past, The only radiotherapy option available to them would be conventional radiotherapy. This refers to moderate to large areas of treatment over a long period of time, 6 to 7 weeks, occasionally combined with chemotherapy. Now, while modern radiotherapy techniques have allowed us to conform our radiotherapy doses further to reduce the side effects from treatment, we know that when we move to our second choice of radiotherapy for lung cancer, the cure rates are still inferior to surgery with conventional radiotherapy, and patients will still expect to see about 20 to 30% chances of side effects. Stereotactic body radiotherapy, one of the latest forms of radiotherapy in the 21st century, has resulted in excellent results and has actually caused a paradigm shift in the management of lung cancer. What is stereotactic body radiotherapy? It is a new form of radiotherapy that has evolved in the last 1 or 2 decades, a highly advanced form which harnesses cutting-edge technology and technique to deliver a highly focused beam of external radiation to actively destroy tumors in the lung or anywhere in the body in just a few treatment sessions. And because stereotactic body radiotherapy is entirely non-invasive and it causes minimal or no damage to the surrounding organs, this has emerged as a key treatment option in the medically inoperable patient with early-stage lung cancer. In our fraternity, we are very fond of this treatment, and many of us refer to it as the lightsaber of radiation, right? Kind of like a laser, a lightsaber that shoots precise laser beams to the tumor. How is SBRT delivered? I think the key advantage of stereotactic body radiotherapy is that it is able to fix the lung tumor at a position where we want to treat it. The problem with a lot of lung and liver tumors is that they move. And oftentimes when we treat them, the worry is that we miss these tumors, which is why conventional radiotherapy will treat a large area. If I know that a lung tumor is going to move from here to here, I'm going to treat the entire area. And that results in a lot of side effects, a lot of uncertainties in the treatment. What stereotactic body radiotherapy, or SBRT, does is that it fixes, first of all, the patient in a very sometimes crude way. This is like shrink wrap. I mean, the patient is being shrink wrapped here. But basically it works, right? You got something a very fixed mold that prevents the patient from moving, and you have something above it that wraps the patient. The other thing that we do is that we try to fix the tumor internally. This is something like a scuba diving device that we put in the patient's mouth. What it allows us to do is that it allows us to control the volume of air going into and out of the lungs of the patient. It's more of a self-directed treatment. The patient looks at the screen. When he breathes in, he sees the amount of air going in come to in numbers, and he breathes out, he sees the same thing, right? And so if I just illustrate this on this video, if you just help me to click on the video, please. This is a patient who's having that treatment. This is the screen that is projected in front of the patient, in front of us, right? And you can see that the patient breathing. You see the various waveforms going up and down. And what we do during treatment is that we ask the patient to breathe in a fixed volume of air and to hold it there. And she's just going to do that now. This patient is going to start breathing here. You see that going up, the volume of air coming, and when it hits a certain level, the patient holds their breath. And when we are sure that the tumor has now been fixed in that position, we start the treatment. And so we are literally treating the tumor in a fixed position where we know it's going to be. Okay? This is the planning process. We use PET-CTs and so forth to draw the tumor, and then we use specialized techniques to deliver the radiation in a highly precise and focused manner. And so these are the machines that we use nowadays for stereotactic body radiotherapy. Not the barbecue. This is not barbecue. This is not shining. This is not frying a tumor, but we are rather targeting a tumor precisely with high-end machines. And this is a report from a very prominent cancer center telling us that non-invasive SBRT radiation for early-stage lung cancers can be a curative alternative to surgical resection in early-stage lung cancers. Right? Just to summarize the report, it has actually said that SBRT can now be considered a safe and effective alternative to surgical resection in early lung cancer. Okay, it has been also approved in guidelines. This is the ASTRO, is an American body, international body, which issues the most definitive and respected guidelines in oncology, and they have endorsed SBRT as the current standard of care for early lung cancer patients who cannot undergo surgery. Now, I know that my time is up. I've still got quite a number of slides, so I'm just going to give me another 5 to 10 minutes, and we'll try to go through the rest of our slides. Stage 3 lung cancer, okay? Treatment hasn't changed much over the last few years. We know the main treatment is still radiotherapy combined with chemotherapy. However, what we know now is that we have a new modality of treatment in immunotherapy for 1 year. These are the latest reports just published last year and earlier, and just a few months ago, establishing Durvalumab as an addition to chemoradiotherapy in stage 3 lung cancers, which has both improved progression-free survival and overall survival. We're going to move on to something most interesting, okay? So this is the most important part of the talk, and that is how can we treat stage 4 lung cancers. The conventional thinking in stage 4 lung cancers is that it is a death sentence. We are looking at 3 months and 6 months of treatment. What we are finding out now is that not all stage 4 cancers are equal. There is increasing evidence to show that stage 4 cancers belong in a spectrum, where some perform better and others worse. Obviously, we are continuing a huge amount of research in this topic, and we are slowly unlocking the keys to identify which type of cancers are good and which type of stage 4s are bad. Obviously, the main treatment for stage 4 cancers, given that it has spread, is still systemic therapy. This refers to treatment that is injected or ingested into the body, okay, to spread throughout the body and to administer reduction in size and some control of the tumors that are available. There are options such as targeted therapy, immunotherapy, and chemotherapy, but this is still the mainstay of treatment, with recent data trusting radiotherapy into the spotlight in the management of such cancers as well. In the not too distant past, my medical school days, and I think most of you can tell that I'm not that elderly at the moment, stage 4 cancer was treated as a single entity. Okay, we would treat them as stage 4. We only have a few options available to the patient. We look at the patterns of the cells. We identify 1 or 2 different cell types, and then we prescribe chemotherapy to them. And I think many of us would identify with this paradigm just 10 to 20 years ago. However, in the 21st century, a multitude of changes have taken place. We now have receptors, have identified a multitude of receptors in the lung cancer cells that allow us to target these cells more effectively, more precisely, and in a more personalized way. Okay, this is a slide that we have seen before. It all gets a bit confusing, right? We see all these markers, say, what does it mean to me? I don't really understand. If you allow me to explain to you with this game that I admit I play with my sons at Time Zone. This is a transformer game, okay, where you actually use a gun, okay, it's a first-person shooter, and then you shoot Decepticons. All right, so it's a game I enjoy very much. But what's interesting about this game is that at every level, there is a big boss in the game, right? And of course, this big boss has a large amount of life. It deals a lot of damage to you. And what the system does, however, in the middle of this big boss fight, is that it actually identifies certain areas that you have to shoot, right, in order to deal a large amount of damage to the big boss, right? What we call weak spots in the armor of the big boss. Why I'm bringing this up is because when we talk about molecular testing in lung cancer, we are doing the same thing to the lung cancer as the game is doing to the big boss. We are identifying kinks in the armory of the cells, of the cancer cells, that we can then target and deal a large amount of damage to the tumor with the least amount of effort. And for every single target that we have identified with our molecular testing, we now have a whole range of targeted treatments that we can use in order to achieve the desired effect. And this is really exciting. It has changed the paradigm of lung cancer treatment. We are not looking at 1 or 2 drugs that go in like a nuclear weapon, destroy everything in its wake, and leave the patient to recover. We are looking at targeted treatments, targeted towards molecular targets that are found in the gene and the molecule of the cell. The same goes for immunotherapy. This is the next big thing, or rather the big thing in lung cancer. It is a form of targeted therapy as well, but the difference here is that it actually goes into the system and it actually stimulates and activates our own immune system to fight the cancer. Okay, so as we all know, the concept of immunotherapy is that there is such a thing as a stop button to our immune system, right, in our body. The cancer cells somehow have this ability. Cancer cells are intelligent. They have an ability to press this stop button and to prevent our own body from targeting the cancer cells. Immunotherapy are drugs that come in and actually prevent the cancer cells from pressing the stop button. In essence, it removes the brakes of our immune system. And we all know that our immune system is powerful. It fights infections for us. And the question is, why not? harness our own immune system to fight our own cancer cells. And this is what we are seeing with immunotherapies. We are seeing excellent, unprecedented responses when we use Pembrolizumab, a form of immunotherapy, as compared to conventional chemotherapy. We are seeing patients live much longer and having much better response rates to their treatment. These are some reports that shows that if we can effectively harness the immunotherapy to use in our cancer fight, we are looking at not just at control for a few months, we are looking at control potentially for years, and in some cases up to 70 months in our patients who are currently receiving treatment. Okay, so let's end off with radiotherapy, again my pet topic. It's all well and good. When we think about immunotherapy, we think about how immunotherapy can control cancers for a long time. But the problem is that in our studies, in what we have shown, we are only able to do that in a very small percentage of patients. It's working in about 20 to 30% of patients. Only about less than 5% of patients are having long-term survival rates with immunotherapy. And if we think about how we drive a car, okay, let's talk about cars, right? If you want to drive a car, if you want to get that effect, it's not just about releasing the brakes from the car. We have to press the accelerator. And so the question that we're asking now, all of us are asking in the scientific space, is how do we effectively press the accelerator and allow this treatment to be as effective as it can be? Radiotherapy can provide that solution, can potentially provide that solution, because what radiotherapy does is that it accelerates the immune system. By killing cells, by targeting the local cells, it releases tumor markers or cancer markers into the system and thus accelerates and activates the immune system. And the hypothesis now is that if we do that in combination with immunotherapy, we press the accelerator and we use immunotherapy to remove the brakes, we may potentially get a home run and a car that's going as fast as it can. Okay, and it's not just a theory. This is a paper that was published last year by MD Anderson Cancer Center. It was a phase 2 trial involving 100 patients with combination of radiation and immunotherapy. And what we have found is that between up to 60% of patients have responded to this combination of treatment. The other expanding role of radiotherapy in stage 4 cancers is in treatment of patients with limited stage 4 disease. Going back to our discussion on the whole spectrum of stage 4, we know that there are groups of patients who have spread to only a few sites in the body, perhaps 2 or 3 sites. They are called stage 4. But the question is, are these people really end stage and are they terminal? I'm going to show this as my last infographic page. This is hot off the press. It was published in October 17, just 3 weeks ago. This was a study done by a Canadian group that has shown that when we give SBRT to selected number of patients with up to 3 sites of spread, stage 4 patients, no less, 3 sites of spread, we have actually been able to increase their survival, double their survival to 46% in not 1 year, 2 years, but in 5 years. And this is unprecedented, it's groundbreaking, practice-changing news that we are looking at 5 years survival now in patients with stage 4 disease. And so as we end, this is what my third last slide, making lung cancer's worst nightmare come true. How is 21st century warfare like? As we said, we now have the tools to recognize the cancer in the form of advanced imaging, targeted biopsy, and molecular analysis. We also have the tools to treat cancer effectively, okay, whether in a personalized manner, dependent on their stage, dependent on their molecular signatures, and even in combination to increase the effectiveness of our current existing treatments. If it's all a bit too much for you to assimilate and to bring home, I'm going to break it down to something simpler, okay? Let's bring it to the 3 Ps. The 3 Ps that we recognize in lung cancer treatment in the 21st century is that it is first precise, whether with radiotherapy or surgery or with targeted therapies. It is personalized, depending on the molecular signature, and last of all, it is promising. And for those of you who still cannot remember this, I want to break it down to this final comment. You can just bring this home, right? And I think this comment really means a lot because it does tell us the relationship between patient and oncologist, right? None of you want to see me, and I do not want to see any one of you, right? And I always tell my friends, my acquaintances, I hope to see you again, but not here. I want to see you outside, you know? And it's the same. We hope not to be able to have to attend these forums, right? We hope that there's no cancer. But unfortunately, the hard fact is that there are cancers, and cancers are here. But the key is that when we finally get to face cancer, how do we approach it? We have the tools with us now, and we can potentially give cancer a run for its money and we can make its worst nightmare come true, hopefully in the next few years, in the next 10 years, or perhaps in the next century. So with that, I will end my talk, and thank you for your attention.